Assalamu alaikum. Today's our topic of discussion is central serous chorioretinopathy. Central serous chorioretinopathy is basically a neurosensory retinal detachment. It may be acute or it may be chronic. Acute is localized neurosensory detachment in the form of a dome, and usually its time period goes up to 3 months or maximum 6 months. While chronic CSCR time duration is more than 3 to 6 months. In chronic, there are RP changes, shallow subretinal fluid, and even choroidal neovascularization can develop. So the presentation is usually a young middle-aged man, type A personality coming in your clinic and complaining of blurring of vision in the one eye, and many people have believed that there is a role of corticosteroids also in this, so they attribute emotional stress and these factors also related to the personality of such patients. So this is a very beautiful image of a patient presented to my clinic, and here we can see in number 1 section there is dome-shaped elevation of the central macula, and number 2, in the cross-sectional area of retina we can see the elevation, and under the elevation there is fluid, subretinal fluid. And if we talk about the central foveal thickness, that is crossing, you can see in number 3 more than 500 micrometers. So when we talk about the treatment modalities, usually it is self-limiting, and we ask patients to wait. If possible, from internal medical side, we ask them to discontinue or at least decrease corticosteroids. Then we have photodynamic therapy and Avastin role. We will talk about it. But before starting this treatment, we should know that CSCR is basically a choroid disease. And if there is choroidal neovascularization in CSCR, Avastin injections, Lucentis, these can be given. But in simple CSCR, it is not indicated. Now the question comes, how to detect CNV and OCT in CSCR patients. So CNV usually present as we can see an OCT. There is subretinal hyperreactive material. We will show you in the next slide, and there will be also some interruptions in the retinal pigment epithelial layer. Now in this picture I have taken from American Academy of Ophthalmology website. In the first red circle we can see that just under that irregular layer there is some hyperreactive area. So this most likely indicates CNV presence. Retinal pigment epithelium has lost its normal contour and it become more irregular. And if we go in the lower slide in OCT angio, we also see there, as compared to the left one, in the lower circle we see there is a haze over there which is showing us more about the choroidal neovascularization. Furthermore, there is another treatment, very promising, and which has been tried for years, and that is photodynamic therapy. Patient is given a dose of injection verteporfin, IV. The dye goes in the body, even in the retina. With the laser machine, this photoreactive dye is activated with laser. It produces free oxygen radicals which damage the endothelium of the choriocapillaris, and ultimately there is platelet aggregation and closure of those choroidal vessels. This is called cold laser. I mean, the power of the laser is very low, and especially those vessels which are harmful, choroidal vessels, those are targeted. A very beautiful study which was conducted in 2014 and published it in Eye, it shows that with photodynamic therapy, the best corrected visual acuity after 1 year can show improvement of 1.8 lines. Subretinal fluid after 1 year will be reduced to 94.9%, and central foveal thickness can decrease up to 161 micrometers, and there will be no fluorescein leakage. So these are different treatment modalities which are available, which can be tried, and but there is no gold standard treatment. The physician has to weigh all these things which is available with him, and then he has to take the patient into confidence and then start the treatment. Thank you.